Well, as you're stretching, thanks so much for the chance to come in here and have this conversation. And I have to tell you, I wish I'd met Dr. Lindquist and Peg and her team about, say 8 months ago. Where were you people when I needed you to help figure this out? But it's great to be able to come and talk a little bit about what we've learned and to also see it from Cathy's perspective on kind of a local level. I'm going to do just a piece of introduction because it'll make the rest of the story make a little bit more sense. But you may be aware that AMR is a national company, but it's pretty big. We'll transport about 3.5 million patients this next year. I'm responsible for the work of about 19,000 caregivers in about 2,000 communities. We're in 40 states. Also, we are the National Ambulance Organization for Trinidad and Tobago, so we have some offshore experience and some partnerships in India as well. So that's a piece of the way that we looked at this was from a fairly high level, and my role is national. But all of our work is done locally. So part of our job was to communicate effectively, make sure we were supporting the local practices in the way we needed to. The other thing that's important to understand is AMR is one of 3 companies that are sister companies in a larger healthcare corporation called Envision Health. You won't hear me talk about Envision Health anymore, but AMR provides medical transport. That's the area that I work primarily. We also have a sister company by the name of MCare, which provides physician contract services, emergency medicine, anesthesiology, outpatient surgery, terminal radiology, and so on. So we have partners real close by who know a lot about medicine and hospital functions that prove to be very helpful in our response. Then we have a third company called Evolution Health, and you'll hear me talk about them quite a bit. That's our newest sister company, and they're an integration company that provides mobile integrated care, and we use their resources a lot. They have physicians, they have a national call center, they have mid-levels, and they proved extraordinarily helpful in overall what we did. So we had this really interesting opportunity. At the same time, all of you were talking about, we provide 911 in all of these communities, but over the third quarter of last year, or the fourth quarter of last year, we responded on, or we screened almost 800,000 patients for Ebola, and identified 286 of them that had the appropriate symptoms and also had been to the appropriate places, and were treated as Ebola patients until proven otherwise. Not a one of them diagnosed positively at the end of the day. A ton of them had malaria. A ton of them had malaria. But none of them ultimately ended up having Ebola. And then we were the organization that provided the transport of Amber Vinson and Nina Pham, the 2 patients at Texas Press. We were the ones that transported them from the hospital to the aircraft to be transported, one to Bethesda, Maryland, and the other to Atlanta. So in a fairly short period of time, we got a bunch of experience, and we learned some things. In fact, we learned a lot. And that learning, and almost everybody else has mentioned this, I've been practicing for now, it's closer to 40 than 30 years, but in the last decade or decade and a half, we've had 3 back-to-back sort of infectious disease things with SARS, followed by H1N1, followed by Ebola. And I'm happy to say we learned, we got better each time. We were pretty bad for SARS. Unfortunately, we didn't have to be very good because it stayed north of the border for the most part. But H1N1, we had a substantial response associated with that. And we learned a lot about how to communicate with our caregivers, and we learned a lot about the employee health issues on the backside for people that thought they had transported an H1N1 patient. Do we have to isolate them? How do we need to do that? So when everything came during that early September, and you guys remember that time, it was just crazy. Fox News was figuring out that actually you could get it from air and water and people on the bus, and I didn't ever hear doorknobs, but I'm sure they were there somewhere. And then we had all kinds of efforts to just button the country up so no one would get it, and lots of kind of fear-mongering around what could happen, and there were movies and all that sort of thing. And we remembered from H1N1 that communication became a big problem because we were behind the curve through the entire event. We had employees that were nervous about getting it before we had had an opportunity to tell them that they wouldn't. We had, and so on and so forth. So we decided back in this period of time that it was so unlikely that this was not ever going to enter the U.S. Just the odds were we would have to have a patient in the U.S. at some point. We didn't know when, we didn't know where, we didn't know any of the details, but we thought it was just incomprehensible that we wouldn't have one. And so we turned to one of the advantages of being a fairly big organization. We turned to our communications department. We said, we need to communicate quickly and efficiently. And so, and all of this stuff is still up. And I'll give you anything that we've talked about. Cathy can get it for you. You can go online. But there's a website, amr.net. We recruit employees through there. It's not actually an internal site. It's an external one. And we said, let's put everything there, because then our employees can get it, our partners and communities can get it, anybody that wants it can get it. And so there's an area right at the top there in the little letters you can't see that says Ebola updates. And so during that week in September, we put this up. We put a little cover letter on it that said, everybody's talking about this, so this is where we're going to communicate. And our really primary mission at that point was to start trying to counteract what people were seeing on the news. And to try and, you know, and both Peg and Dr. Lindquist mentioned, to try and talk about the science and say the science is this. And the science is, this isn't real hard to protect yourself from. We also remembered painfully, and me probably more than any of our other senior clinical leaders, because I've been practicing longer, what HIV was like, and how many people refused to care for patients, how much sort of profiling was going on. I don't think I'm going to care for that patient because he looks like he could have HIV, which of course was just absurd, but it was so morally wrong. And it was born in part out of ignorance. So we thought, well, let's see if we can push this out, because unfortunately you could profile this one if you thought narrowly enough. Well, you're black, you must be from Africa. I don't think I should treat you. So our real mission at this point was just to get information out. And so that's what we did. This came out about 2 weeks because, as you all know, this was common fluid and contact precautions. This wasn't anything exotic. And everybody's been trained. Everybody doesn't do it, but everybody's been trained. So we thought, well, let's put out a document that reminds everybody when you have to put on gloves, when you don't, what procedures require what degree of effort. So we found some, I mean, it's all CDC material, but I found this chart that somebody else had put up, this sort of a format. If you're going to talk to patients, what do you have to do? Nothing. If you're going to touch them and do an assessment, what do you have to do? If they don't have blood and body fluids, nothing. And so on through common patient care procedures. I really loved the way that they organized it, so I stole it. Put our information in. I mean, I just stole the format because it allowed our crews to look and say, I'm doing vital signs. What do I have to do? Nothing. I'm going to start an IV. What do I need to do? So it kind of helped organize things with the thought that if we were lucky, people would be thinking about this and starting to engage around this information before the Ebola craze came to their community and they started worrying, because then we could say, remember the poster? That's what you need to do now. We just talked about that. So I don't know if you've got any comments on what the poster and those early things looked like here, or if it was all invisible to you at this point, because we do that sometimes. We think we're doing a great job sitting in my chair, but nobody else has ever heard of it. So.
No, about the same time period as AMR, the corporate was putting out the information. They asked for people at every operation to kind of become the expert for the operation in the region, and I volunteered for that position here. And so as this information was coming out, I was feeding it to our employees through emails, posting it around our buildings, putting it in mailboxes, and making sure that they knew where they could go for the resources that they needed. And also, I think you're going to touch on it a little bit later, but just the difference between a person under investigation and the actual Ebola patients, and differentiating that in our caregivers' practices.
Yeah, and that's a really good point. When you got 19,000 employees all over the place, you can't just put something up on the cafeteria wall and be pretty sure. It's about half of my career has been in hospitals, and that works great there. Or in the stalls in the bathroom, I've been pretty successful with that strategy too. But I can't get to all the bathrooms from my chair. And so, you know, Cathy reminded me of something I'd forgotten. With H1N1, we put out a lot of great material that nobody ever saw. And we suddenly realized what we had to do was have a designated contact in each practice whose job was to take in information, distribute it, and then they also were the person that would call me and say, we have a question, we don't understand how to do such and such. And so that really was a critical part of it. So September 30 comes, and we have the first Mr. Duncan in Dallas. And so we'd already created, I don't know if anybody had gone there, but we'd already created a place to put this stuff. And so we sent out the note that said, okay, it's here. Now, we had actually played with it a little bit, and I say that almost literally. We had 3 incidents in Texas. Why Texas, I don't know, because it was before this case occurred. But we had 3 incidents in Texas where physicians called AMR operations and said, I'm pretty sure I've got an Ebola patient here, and I need you to take them over there quickly. I don't want them here. I want them there. And so those local leaders called us and said, what do I do? And so we started turning around and calling those physicians back to say, first, does there know they're coming? No, that's just where they should go. Okay, there's problem number 1. We don't want to just drop in, whether you're right or wrong. It's kind of like taking a burn patient to a hospital but not telling them you're coming, and so they can't really be ready. Number 2, help us understand why you think those patients have Ebola. Well, they knew somebody from Africa once. I mean, they were very loose associations. And so we were able to kind of de-escalate those transports. We still did them, but now we weren't worried about Ebola because there was no way on earth this was Ebola given the history and that sort of thing. So we'd already started engaging on that. So on September 30th, we began putting out information, and we made a policy decision at that time, which I will stand by to this day, which was we're going to trust the CDC. And you'll remember what the news was saying about the CDC about the time the Texas case occurred. We told you this was going to happen. You should have buttoned up the borders. And they rode them pretty hard for, I don't know, 6 weeks. And were sure that they were doing anything wrong. And it took us all of about 45 seconds to say, you know, we're going to disseminate their material. And the vast majority of things we posted on the website were simply their stuff. We didn't relabel it. We didn't do anything with it. We just set it there and said, here's the newest, latest, greatest from the CDC. But we tried to put it all in one place so people didn't have to shop too far to find it. So you can see, again, in little letters that remind me of something, but you can't really read them. With each passing day, we were posting more things. Guidelines from the CDC on risk factors, guidelines from the CDC on appropriate assessment, guidelines from CDC fairly early on the safe transport, and those kinds of things. And then as they updated, as they did, then we would update that information as well. About the 7th or so, and it was the 30th, if you'll recall, that the case was confirmed in Dallas. About the 7th of October, we had placed the 2 Ebola questions in our electronic medical record system. So we would have a prompt that would come on the screen to remind crews to ask the questions, and we have a way of tracking to see how things were going. And it would give us a point of focus to talk to people and say, don't forget, you need to ask these questions, and it's embedded into the electronic medical record, so that'll hopefully make it easier for you to do that. So at the same time, we created this little chart, again, thanks to our communications department. It is, the wording is verbatim out of the CDC. I mean, we didn't make anything up. We just created a pocket card that people could carry that would remind them of the questions they needed to ask and what to do if the answers to both questions were yes. And I believe about 1 billion of those got printed all over the place and distributed. And again, we put them all on the public website so anybody that wanted them could have it. On October 1st, we started talking to our call centers. We actually have 17 accredited call centers that screen millions of calls a year from 911 callers. And it was at about this time that the folks at the CDC were considering whether we wanted to do different things to call centers so that a call center would end up notifying or responding ambulance that there was a possibility that a patient had Ebola, so that they wouldn't be knee-deep in the patient before they discovered that and have to kind of back their way out of the compromise. And so we started working on that at about that same time. And the biggest reason this is up is to tell you another story, which is Texas Presby taught us something, and we started believing it here, and they taught us about a week later. I don't know that I can confidently believe that 19,000 caregivers will do this right every day, 7 days a week, in the dark, in the cold, when they forgot. Bless you. And it's not actually anything to do with my confidence in our caregivers. We have fabulous caregivers. But if the experts were having breaches, and that does sound really nasty, I must say. I hadn't thought about it, but it sounds like a criminal act. But if the experts were having complications, people that wear gowns and gloves every day in the OR and ICU, EMS crews that wear them once in a blue moon for a patient who's vomiting uncontrollably and might have hepatitis, we were concerned as to whether it would be okay. And we also were concerned that our crews have somebody they could turn to get advice in cases like hospitals that say, I have an Ebola patient, you need to move them. How do we, should we move them? Should we not move them? Are they stable enough to move? Who's going to call the receiving facility? And so on the 1st of October, we lit up the Medical Command Center that runs every day for our colleagues for Evolution Health, where they are a distributed, mobile, integrated healthcare system with immediate consultation from a dermatologist or a pulmonologist or whomever, so that the clinician that's seeing a patient in their home has some backup and some capacity to make decisions that don't involve, well, let's just take them to the hospital, which is not where the patient wants to go. It's not where the care system wants them to go. It's not where the payers want them to go. So this command center already exists, and it was working full-time coordinating caregivers in the mobile integrated space, and we asked them if they would be willing to take calls from ambulances, so that if they thought they had an Ebola patient, what they needed to do was call the 800 number, and we would be happy to help them. When they called that number, they got somebody who was a medically trained nurse who was answering the calls, highly protocolized, and they talked to one of 4 of us, every one of those calls, and there were hundreds. We did never break 1,000, but there were hundreds. And all of them were between 2 in the morning and 6 in the morning, I swear. They had to be. Dr. Ed Rocht, who is our Chief Medical Officer, Dr. Eric Beck, who is now the CEO of Evolution Health, but at the time was the Chief Medical Officer for F Health, myself, and a fellow by the name of Jonathan Segoo, who's an advanced practice nurse who practices in Dallas. And so every one of those calls came to one of us. And we essentially said, tell us, and we helped them through the questions. So, and I mean, just to give you a sense, they were fun, kind of. Again, with the degree of funness changing depending on the time of night. But you got such a great perspective. We had a great crew, done their work, everything's fine, they're with the patient, they're getting ready to transport, and they just want to make sure that this patient's a person under investigation, and we need to drape the ambulance and coat ourselves in Tyvek and all that sort of thing. Well, tell me about the symptoms. Well, he's got runaway vomiting, maybe a little blood in his vomit. For 10 days, he's lost a bunch of weight, he can't hold food down, he's dehydrated. That sounds pretty good. So you got a fever, yes. And the fever was 102 or something, I don't remember what it was. It's like, okay, tell me about his travel history. Well, he's been to an at-risk country. I said, okay, where? Which one? He was in Houston. And I had to stop for a second, and I said, like Texas? He said, yes, sir, in Texas. I said, well, why are you thinking that's... Help me with this. I'm confused. It is 2 in the morning. I'm just confused. He says, well, they've got Ebola in Texas. It's like, well, true. They have 1 case of Ebola in Texas, and it's hundreds of miles from Houston. And he was trying to do the right thing, and we felt like providing that capacity for them to talk to somebody, kind of phone a friend, and figure this out was really helpful. And to hear the relief in his voice when I said, he's not been to Africa, no. To West Africa, no. And then there was a lot of geography that went on during those calls. He was in Africa. Where? South Africa. It's south, right? No, it's west. Was he in any of these 3 countries? No. You're good. Has he been with anybody that's been there? Is he a healthcare? No, you're good. And so those calls, we think, reduced a lot of the fear for the caretakers, helped them make good decisions, and then we ran a ton of interference. Some of our biggest challenges were around receiving facilities. I was on the phone for 4 hours one night with a crew that was in front of a hospital that refused to take the patient. And they'd actually put security in front of the doors and said no. And this is in a 1-hospital town, so it's not like they can go anywhere else. And so I ended up calling the hospital CEO, who ended up calling, and so we provided some background work to help with some of those challenges. And I think it was one of the better things that we did. As I said, Texas Presby taught us, it's a fabulous hospital. We have lots and lots of presence in Texas. Our medical command center is in Dallas. So, I mean, we know this hospital really well, and it's a great hospital. And if they could have an exposure in the ICU of one of the best hospitals in Dallas, why would we believe that 19,000 caregivers driving around in 4,000 ambulances wouldn't have an exposure? And so the other piece that happened at this time, and we'd been thinking about it, but this really confirmed it, was part of what happens when you call the call center is we say to you, who's going to go on this call with the crew? And we suddenly have made donning and doffing a 3-person process. Our folks work in 2-person crews, and so in most cases they'd send a supervisor. In a lot of cases I was talking to the supervisor while the crew was doing what they did. And they became the donning supervisor and the doffing supervisor and kind of the safety officer stand back, make sure nobody does anything too quickly, because that's where mistakes happen. Just slow down for a second and work your way through this. And so we learned a lot from their experience as well. So from that point on, we put out a lot of guidance, and all of Peg's team commented on lots and lots of policies and procedures and guidance. Our guidelines around when did you need to drape an ambulance, and one of the things that the CDC talked about, but they didn't put out specific guidelines differentiating, was between a confirmed case and a patient under investigation. They didn't differentiate how you would protect against one or the other. We found we really needed to make sure, and so we treated all the persons under investigation as if they were confirmed. The 2 confirmed cases we had, and I'll talk about that in just a second, we ramped up a little further. But it was the only way we knew to be safe until they were diagnosed. And like I said, none of them proved positive. But it was we thought the right approach to that. And so we put out a fair amount of information on, here's a person under investigation, here's how you prepare for that. And then a fair number of documents around employee health. If an employee felt like they'd been with I now have transported a 52-year-old male who has fever, vomiting, and rigor, and was just doing missionary work in one of the countries under concern. I've now transported him to the hospital. What do I do now? Do I need to be beached? Do I need to sit home? Do I need to stay away from my family? So we had to create employee health guidance around that also, as to how we didn't actually monitor them in the formal way that the public health does, although we did for the patients or the crews that transported the patients in Dallas. But we developed guidelines so the local leaders like Cathy would know what to do with those people and what to tell them and how to monitor that.